everyone. Today is our first webinar, which will start a series of meetings almost every Thursday on current topics of functional neurosurgery. To open our webinar, I present the president of the Brazilian Society of Functional Neurosurgery, Professor Antonio Almeida. Antonio represents what we stand for in this specialty: knowledge, honesty, and perseverance. This webinar is taking place because Antonio Almeida's commitment to the evolution of the quality of functional neurosurgery in Brazil. Dr. Antonio Almeida, please.
Thank you, Paulo, for your kind words. On behalf of the Brazilian Society of Estereotaxia and Functional Neurosurgery, I'd like to thank everyone involved in this project. It's not possible to name everyone who contributed to these webinars. It was an effort from our society to spread knowledge about our specialty around the world. However, it is essential to show our recognition to the president of the Brazilian Society of Neurosurgery, Dr. Borba, that gave us all support necessary to go on with this project. Dr. Brainer also deserves mention and has organized the scientific program. Finally, I'd like to thank all speakers and moderators that gave their time to share the experience with us and the audience, which is the reason for our efforts. Thank you all, and let's go to our first lecture now. Dr. Aziz, it's your time now.
Very well. Before starting our webinar, let's all agree how to ask questions and comments today. All questions and comments will be made after the presentation of Professor Tipu and the comments of mediators, Professor Alessandri and Manuel. Questions and comments can be sent by clicking on the Q&A icon. The chat icon will only be used for other subjects, such messages between everyone. Everything well explaining. Well, let's start now. Today's topic certainly interests all of us because over 70% of the world population suffer from any kind of pain, and despite pharmacotherapy, many patients' pain is refractory. Today's guest is an open lecture, very important. We have selected the most important group of neurosurgeon, professor, and heads of medical residence programs. Dr. Alessandro Francisco is a professor and head of Neurosurgery Department of Hospital Universitário do Cajuru, Curitiba, Brazil. Dr. Manuel Jacobsen Teixeira is a professor at the University of São Paulo, head of Neurosurgical Clinic and Functional Neurosurgical Division of the Hospital das Clínicas, University of São Paulo. And finally, Professor Tipu was the founder, and today he is the head of Functional Neurosurgery at John Radcliffe Hospital at the Oxford University, United Kingdom. I also like to say that Professor Tipu lost someone very close to him today. My condolences, Professor, and thank you very much.
Thank you.
I would like to say Professor Tipu has received a prestigious award at the Britain's highest neurosurgery honor from the Society of British Neurological Surgeons in recognition of his contributions to British neurosurgery and for a lifetime work in neurosurgery that helps to share best practice and knowledge with the specialists of the benefits of the patients. Professor Tipu, thank you very much.
Thank you very much, Paulo. Thank you. I'd like to say also that Brazil and Oxford has had a very, very long tradition of association. Manifest some years ago, some of you may remember, that the SBNS and the British Neurosurgical Society had their meeting in Oxford. And therefore I thank Paulo, yourself, and Professor Almeida to present my experience on deep brain stimulation for pain. So let me see if I can start sharing this talk successfully. Let's see. So what I'll do now is talk about a great interest of mine spanning nearly 3 decades, deep brain stimulation for neuropathic pain. Now, what do we mean by neuropathic pain? The definition has been quite simplified in recent years. It's pain caused by a lesion or disease of the somatosensory system. And as Paulo had mentioned, neuropathic pain is estimated to affect as much as 7 to 8% of the general population in Europe. And of this huge population, 5% of them are disabled despite best medical therapy. And we need new therapies to deal with this problem, as manifested by the huge problem that we see in the United States of opiate overuse. We have to find a way to reduce that risk. Now, deep brain stimulation isn't new. One of the pioneers was Jose Delgado, a Spanish surgeon who worked in Spain and also in the United States. And he was able to show that he could control with this radio frequency device, this implant, the first of its kind, called the stimoceiver. And here he demonstrates that he can control the behavior of a crazy fighting bull by remote control. And you can see here, the bull has had a stimulator implanted, and he's chasing Delgado's DPhil student around the arena. And then Delgado, who you see here, turns the stimulator on and stops the bull in its track. So he was able to show that man can control possibly the mind with deep brain stimulation. Another pioneer working in Tulane in the US was Don Richardson, and he's still active. And what he was able to do was use homemade implanted electrodes. In those days, he didn't have an implantable device like Delgado. And so he was able to study the mechanisms of pain. This illustrates a cat, anesthetized cat, with a stimulator implant in the sural nerve while he's recording from the brain structures. And he could show that stimulating the sural nerve elicited this delayed potential, which was associated with a perception of pain. He was able to show that if you stimulated the spinal cord, you could abolish that message. And this is long before spinal cord stimulation came to being. He was also able to show that if you stimulate an area he called the central gray, we would call the periventricular gray now, could also block this delayed response. And it was mimicked totally by morphine. So it did have an analgesic effect. And so what he went on to do in Tulane, in collaboration with a neuropsychologist Heath, was to implant electrodes and externalize them. And because in those days, people didn't really have an idea of what the best targets were. And so Don Richardson would implant up to 30 electrodes with 50 contacts into the brains of patients and externalize them. And in those days, they didn't have small computers or anything. And this externalized connector was plugged into a computer. And they could look at the effects of deep brain stimulation in multiple areas and the effects on pain and psychiatric disorders. And this is one of the Heath's patient, a patient who's severely depressed. I won't play the sound, but look at her expression when he stimulates. Here she is emotionless, lying flat on the table. And then he applies stimulation, and then look at her face.
You almost look like you're smiling a bit. Are you?
Nice.
Bob Heath implanted electrodes in the brains of chronically depressed patients, hoping to stimulate pleasurable sensations.
I guess I've cracked up all the way. I don't know.
I mean, that's reading your smiling.
So you see, from a total lack of emotion in her face, deep brain stimulation in the area that we now know very well, the nucleus accumbens, reversed the symptoms of depression. So they were able to show that deep brain stimulation could control a lot of human suffering. So despite that, in the US, deep brain stimulation for chronic pain was trialed with the fully implantable early Medtronic devices. And surprisingly, they're considered failed trials. And yet, in the 3380 trial, 196 patients were enrolled, and the center trial reported 1993. And although it was reported a failure, 46% of the patients reported persistent relief at 1 year. The 3387 electrode trial showed that of the very few people that came back, 16% reported persistent relief. Now, 70% of patients in these trials were lost to follow-up. Now, why did they lose follow-up? Because patients were expected to appear after successful stimulation to have it switched off to look at the results and then turned on again. Now, imagine if you have an implanted deep brain electrode and you get good results, are you going to go back into a trial that might remove the pain relief? So, of course, those trials failed. Other case series have shown how successful it is. Don Richardson's study from the early 70s showed that initial success was 90% and long-term success was 60%. And if you look through the numbers, the success rate of deep brain stimulation was quite variable and reached almost 77% in the series by Hosobuchi, who tragically died a few years ago. So in the early 90s, after failing to control pain with motor cortex stimulation in Oxford, we decided to revisit deep brain stimulation, which by that time in North America had died. So we started taking up implanting standard old targets. And the way we do it is, first of all, patients that we consider suitable, which I'll go into, have a brain imaging performed. And then we can compute the trajectory, and the surgery is done under local anesthesia using the CRW frame. And we don't use burr holes in Oxford. We make the skull penetration through a 2.5 millimeter twist drill and implant the electrode. And we generally, until funding was removed for deep brain stimulation by the NHS, we would trial the patient for a week. And if successful, under general anesthesia, implanted a generator and connected everything up. Now, this is a patient that I did with phantom limb pain. And if you touched his thumb, he would suffer the most incredible agony. And this is him on table. And you can see he's wide awake. There's a stump, and the slightest touch of this cloth caused severe pain. And yet when we stimulate it in his sensory thalamus, here you can see we're touching him and there's no reaction to the pain. And he's stable more than 15 years after the surgery. How does it work? It's not clear even now whether deep brain stimulation's effects are due to activation or inhibition. It depends on stimulation settings, the configuration of the surrounding tissue, whether implanting gray matter or white matter or a mixture of the two, and also the specific anatomy of the targets that we implant. Now, from the work of Don Richardson and Heath and others, there's several areas that might have a role to play in the control of pain. The septal region was the one that Heath elucidated with Richardson. There's also the caudate nucleus. And the ones that have held their own with time are the paraventricular gray and periaqueductal gray area and the sensory thalamus. And more recently, the anterior cingulate cortex. Now look at the standard targets. The periaqueductal gray lies 2 or 3 millimeters lateral to the third ventricular wall at the level of the posterior commissure. And the sensory thalamus lies just inside the internal capsule at the level of the posterior commissure and goes medially in a somatotopic fashion, so that the leg is very lateral, arm medial to it, then the face, and then the midline structures. And if you stimulate in the periventricular periaqueductal gray, if you're right in the right somatosensory area, stimulation there induces a sensation of warmth. Patients report that when you stimulate there at fairly low frequencies, it feels like a warm blanket in the area of pain. And in the sensory thalamus, you try to induce a sensation of paresthesia that is more pleasant than the pain they suffer in the area of pain. So these two targets are very good. They lie in the lateral sensory pathway. They're very good for regional pain, pain like the face, the arm, the leg, where you can somatotopically map the area of stimulation. Who do we choose? We choose neuropathic pain that is refractory to medical therapy for at least 2 years, or they can't tolerate medication. And we implant patients that are referred by clinicians in a multidisciplinary pain team to us. And we try as far as possible to find an organic origin for pain. And because pain impinges on people's psychology, we have a very detailed neuropsychological assessment. And of course, as all surgeons do, we only operate if there are no surgical contraindications like coagulopathy or ventriculomegaly. Because you can imagine, if you have very large lateral ventricles, it's very hard to approach the anatomical target in a somatotopic fashion. And if we traverse the ventricle, you raise the risk of a hemorrhage, and therefore we try to avoid that as much as possible. So let me discuss with you our Oxford pain series. Well, this is over a 12-year experience. And you can see that we assessed nearly 200 patients. And because we work in the NHS, we have to get public funding, and it's not always successful, as you see. 29 patients declined surgery, 15 had medical contraindications, 7 psychological contraindications, and 3 were shown that they could be medically treated. So 87 of them went to a DBS trial. And during this trial period, 87 felt that the pain relief was not enough, or they didn't like this sensation, and 76 went on to full implant. But as I'll show you, over time, we did quite a few stroke patients. And with time, we've lost them to death and insufficient follow-up. So we had 61 long-term outcomes. How did we assess them? Well, we used the VAS score. We used the McGill score. We also looked at physical functioning through pain and quality of life assessments using the SF36, as we call it, and the Euroqual. And we also applied the VAS score to them. And the psychometry was testing intelligence, language, new learning memory, visual spatial perception, psychomotor speed, and executive function. And these were applied through various questionnaires.
Daniel,
so what we could show
quantos casos de isso no nosso?
what we could show then was at short term, up to a year. Sorry, someone has their microphone on. So a short-term outcome at a year, we could show that there was a benefit along all the parameters we looked at. Looking at the VAS, the McGill Pain Questionnaire, SF-36, EuroQoL-5, and the health state. And at 4 years, we were able to show that a significant number showed sustained benefit from deep brain stimulation. This shows the spread of our patients. You can see that in those days, the large majority were post-stroke pain. And then there's spinal pain. And then there was a brachial plexus injuries, phantom limb pain, head pain of various disorders, and miscellaneous other types of pain, which formed a minority. But what is interesting, the etiology dictates success. Phantom limb pain had a very good success rate. Brachial plexus, about 50% in our experience in those days. Spinal pain had a very good success rate long-term. And interestingly, even with post-stroke, we got significant improvement in their long-term pain relief. And we published this in this paper. So what were our conclusions using sensory thalamus and the paraventricular gray? We were able to show that DBS is effective in relieving neuropathic pain of various etiologies. It can show long-term efficacy. The etiology of pain also dictates the efficacy. But what about patients who have ineffective DBS or patients with very widespread pain? It's not uncommon for high cervical injuries or pathologies of tumor to have whole body pain. It's common to see patients with post-stroke to have half body pain. They don't have a somatotopy to their pain. Where can we put the electrode? Therefore, we looked back at our experience and that of the published series of the anterior cingulate cortex. Because in our experience treating cancer pain, when we visited anterior cingulotomy, it had a very different effect to the sensory thalamus or paraventricular gray. When we lesioned there, patients with cancer pain said that the cancer pain was still there, but it didn't bother them. So we thought, with patients with widespread pain, that we cannot target the sensory thalamus or paraventricular gray. We'll try implanting stimulators in that area. Now, the history for cingulotomy is cingulate stimulation. It was long known that frontal lobotomy patients still had pain but weren't bothered by it anymore. And cingulotomy patients continued to have pain, but it was not particularly bothersome. And it was shown that after cingulotomy, patients had reduced narcotic requirement. And surgical anterior cingulotomy, pioneered by Hugh Cairns in Oxford, relieved intractable pain, and it was popularized by Bob Ballantyne in Boston. So we published our series of deep brain stimulation of the anterior cingulate and felt that it was targeting the affective component of pain. You see, pain causes suffering. But if you take that suffering away, that pain becomes a benign sensation. And so we looked at our patients with, after our series, 16 patients with ACC DBS, 6 were failed post-stroke, failed back surgery, post-stroke pain, brachial plexus injury, spinal injury of various sorts, head injury, 1 of unknown etiology. 7 of these patients had a previous DBS which had failed because the pain was so widespread, and 9 were new patients with very widespread pain. This is where we put our electrodes, where we'd put our cingulotomy in. is 20 millimeters posterior to the tip of the anterior horn of the lateral ventricles. We place them between 8 to 10 millimeters lateral to the midline, such that the deepest tip lies in the corpus callosum and the rest in the white matter, as far as we can tell, in the cingulum bundle. Our average stimulation parameters are 5 volts, 130 hertz, and quite a wide pulse width, 450 microseconds. And our early results were quite encouraging. Again, you could see there was a perceived improvement in the VAS, SF36, the Miguel Pain score, Euroqual 5, and the health state in these patients. We've shown you that. And this is a more recent outlook on longer follow-up, which we haven't published yet. And again, we show that 10 out of 12 patients with long-term follow-up showed significant pain relief. And this is a patient who we implanted for stroke with left hemi body pain. And this is what he said to us when the DBS was on. He says, look, I don't actually think about the pain. And then he says, yes, I still feel pain, but I don't think about it. And he didn't have any side effects. And his conclusion was it was working. Unfortunately, several years after, he died of another stroke. So what were our conclusions from that? That anterior cingulate stimulation does achieve good pain relief and improvement of quality of life. You have to select your patients carefully and target carefully. And over longer term, we found that with larger experience, our results have improved. But there have been some unexpected consequences in that with continuous stim, about 25% of our patients developed unexplained seizures. Of those patients, a significant number refused to stop the stimulation because despite the seizures, they still benefited from the pain point of view. So what we did when Medtronic produced their PC plus S, the telemetric device, we were able to bring patients back and look at patterns of stimulation that did not induce seizures. And we were able to show that if you stimulate patients with a slow ramping up and a slow ramping down and apply the stimulation intermittently, we do 1 minute on, 1 minute off, the seizures do not happen, and we can achieve pain relief without seizures. Looking at quality of life by neuropsychometry, we see improvements in bodily pain, improvements in their mental role limitations, and in their physical limitations. And of course, the changes correlate with the change in the pain severity. But I must say that even after surgery, the scores for pain are still significantly different from the normal population. And it has its biggest impact on emotional well-being. So what we would have said from our experience that improvements in pain and disability are comparable to those of previous studies. Improvements in quality of life, of course, correlates with pain changes. Improvements in emotional well-being improve with pain changes. But as I said before, the sample is still impaired compared to the normal population. And what we have shown that all these patients that have undergone deep brain stimulation for pain show a roughly preserved cognitive profile, except in very selective cognitive tasks, which don't really affect daily life. And then a few words on imaging and pain. It's interesting that after limb amputation, when you get phantom limb pain, if you do voxel-based morphometry, there's actually a decrease in thalamic gray matter. And that was something that interested us. And we were able to show that if you look at the volume of the brainstem and thalamus in pain patients, We were able to show in our patients, we hadn't published this because we couldn't compare to controls, but it shows in our series that there's a decrease in thalamic and brainstem volume with chronic pain. And if you look at the upper brainstem, the periventricular gray and periaqueductal gray, and look at patients with a low McGill score compared to our patients with a high McGill score, there is a larger reduction in brainstem volume if you have severe pain. Now, everybody is very familiar with the neural signature of movement disorders. Could there be one for pain? And that was the work of my colleague, Alex Green, who was able to show that if we were recording field potentials from patients with pain, when their pain increased, you see this bursting sort of phenomenon that correlates highly with their VAS score. We also showed that even in the posterior hypothalamus with cluster headache, with the onset of headache on table, we are able to show a very increased activity in this 10 to 20 hertz band, which was absent when his pain was alleviated. So you see, in the days where closed loop is raising its head, it may be in the future that we could find a neural signature for pain that would allow us to better improve our results. But what do we have to do first? In Britain, lack of randomized controlled trials led them to remove funding for deep brain stimulation in the public sector. We will have to design new trials because standard randomized controlled trials don't work with deep brain stimulation. Because if you turn them on or turn them off, patients can always tell through the paresthesia or warmth sensation. The voltages we use in pain make it more economical to use rechargeable. There's not much known enough about whether directional stimulation would help us better our target selection. And of course, with closed loop, could we look at an on-demand pacemaker? So I'd like to thank you for listening to my talk. And Paolo sent me the questions that were raised, and hopefully those issues that I haven't covered, you could bring up now in the time that we have remaining. Thank you so much.
Thank you very much, Tipu. Now, I would like to open to Professors Manuel and Alexandre to comments. Professor Manuel, could you please?
Thank you, Professor Aziz. A beautiful presentation. I have seen your presentations in the past. This is, I think, the best one. We started putting electrodes in periaqueductal gray and the periventricular gray and the thalamus during the 80s. Mm-hmm. And in 1989, we stopped the project because in short term, the results were very good ones, but in long term, the results were not good. And after 1 year, the big number of our patients, they had again the recurrence of pain. And so we discontinued the project. And in Brazil, there was not many other doctors interested in this field. We kept our interest in this approach, but we think that we need new targets. As you talked about the anterior cingulum, we are developing the posterior insular stimulations. We are publishing now, I think in a few months it will be in a neurosurgical journal, 10 cases double-blind study, putting electrode in posterior lingula, based on research that we have done with central pain. We observed that to have central pain is necessary thermal sensory deficit. Thermal sensory deficit is processed in posterior insula. This is why we found this target, and with the advantage about the anterior cingulum that we can make a TMS stimulation to preview the result. So what we found that very interesting results in avulsion, traumatic peripheral nerves, but no good results in spinal cord injured patients. We have not used the procedure in CVA, but this next year, as soon as the COVID went out, we have this project also to follow this line of research using the CVA central pain.
That's very interesting, because the functional imaging studies in Oxford have also showed that the posterior insula could be a target. And my colleague, Alex Green, has just implanted a patient, but unfortunately, with the COVID, we cannot bring him back for follow-up so far. So we'd be very interested to read your paper.
Yes, I can send you a preview.
I'd be very grateful.
Interested in this. Yes, because it's very simple. I think the most important advantage is to use the TMS to preview the results. So we are using also TMS for the stimulation of the spinal cord in pain also to preview the of spinal cord stimulation and feel to have the expectancy of the result. I think it is a very good approach.
How do you approach how do you approach the insula surgically?
First we use the NMR to localize the target point. Using a navigated TMS, we make a stimulation, repeated the TMS, some sessions about it. When we feel that there is a result, and the after effect result, we put the patients in the outpatients in the our theater. We're using fusion of images with stereotomography and NMR images. Using the TMS stimulation, we localize the target point. We published the paper about how to make the calculus in the European Journal of.
I will be very grateful to look for that. I've lost connections, unfortunately.
Professor Manuel,
2 years some changes. I cannot. I'm sorry, but I am ready here.
I lost a few minutes.
Oh yes, but anyway, we're using the image and using also the preview with the TMS. We localize the target using this map. We put just one electrode, not more than one. We make also the recording just to know if the recording has some importance in the target calculation. The postoperative period, we keep the patients without stimulation for 3 weeks. After this, we started the double blind, 1 month on, 1 month off, and again on to check if there is a placebo effect or a effective effect.
Right. You see, going back to your loss of efficacy, which you found in the early years, what we found, our impression was that it is not that they lose the pain relief. But like post-stroke pain and people with severe burning dysesthesia, you stimulate and you get rid of that. And long-term, the pain that they didn't notice because of severe burning dysesthesia, the muscle ache, that starts predominantly becoming a focus. And so they feel that the pain relief has gone. But when I've turned it off, they became very upset that the pain came back.
Yes. Using this approach, as you showed, periaqueductal gray and sensory thalamus, presently we are putting electrode in both sides. There is another project using this approach, but a super threshold stimulation of the thalamus, not to induce paresthesias, but just below 10% less than the parameters that we use to induce paresthesias. I think this is a good approach. We have a few patients, I think 3 or 4, that we have operated months ago. We are evaluating these results.
That'd be interesting to see.
Yeah, but the big problem that we have, at least in my clinic, is the spinal cord injury patients. This is very difficult to treat. No one patient that we have made spinal cord stimulation, deep brain stimulation, infusion of drugs into the spinal canal, we have seen any good results.
Yeah, I'll wait until I get long-term results with spinal cord injury, but we've been finding that the anterior cingulate is quite good for that.
Yes, I will analyze it. I like your presentation. I will following your publications. I will make some mentions in Brazilian books about your work. Yes, but we don't have experience with simulation of the anterior single.
Yeah, we've continued with that. No, thank you for that.
Thank you.
Thank you, Professor Manuel. Thank you very much. Professor Alexandre, please.
Well, first of all, I would like to thank everyone to attend to this webinar, especially Professor Aziz for being so kind and so generous with showing us his knowledge about DBS for pain. And this is obviously one of the most controversial surgical procedures in functional neurosurgery as a whole. And we know that population, at least not this population, but the patients that we may consider deemable for this procedure, they are very, very tough and difficult cases. And usually we do it because we have nothing else to do. And me personally, I have a small experience with in DBS for pain here in Brazil because it's an off-label procedure, and usually government, and neither government or public insurance, they reimburse for this procedure. So it's a tricky situation. In some academic centers, like in Professor Teixeira Center, for example, they have the opportunity to make these projects, which are really, really interesting. I had the opportunity to work with Professor Ron Tasker about 20 years ago. So, and by those days, he was still doing a lot of, I wouldn't say a lot of, but he was doing DBS for pain, at least 1 or 2 cases a month, which is amazing if you think about his numbers. And even though he was very skeptical, some of his remarks about DBS for pain were very, very interesting. And interestingly enough, he had the same experience as you, Professor Aziz. He said that his best patients by those times were patients with failed back surgery syndrome. And it's interesting to think about it, because these patients, they usually have midline pain. And even sometimes with doing unilateral DBS for pain, they may present with some results. But the most difficult thing of it was to find some consistency. So some patients who have more deafferentation pain, or sometimes they have more episodic pain, and they respond very differently. But Tasker, he was very, not only very humble, but he was very conscious about the results. So every time he published the paper, we would expect the worst results possible, and that's because they were true results. They were results that we could rely on his numbers. So I've been very interested in DBS for pain. I have a very, as I said, a very mild experience, and I did a few cases with anterior cingulate stimulation, as you mentioned. And I have more questions than actually statements to make. And one of my considerations is that back in Toronto, we used to do only somatosensory stimulation. So we would stimulate either the ventral caudal nucleus of the thalamus or PVG. I had no experience with internal capsule or any other sensory targets. But with affective, I mean, when we want to stimulate a region to change the affection part of pain, like the anterior cingulate cortex, it seems that we are working in different ways to reach the same goal. Okay. So I'm very interested about your results, Professor Aziz, but I have one question. And have you tried to combine the ACC with any other somatosensory targets? And if you do so, what is your rationale to start stimulating? For example, do you start with PVG and then move to anterior cingulate cortex, or you start with VC and move to anterior cingulate cortex? What is your personal experience or your thoughts about that?
Well, I think now if someone has very focal pain, like the face or the arm or the leg, I would go for the lateral pathways, the sensory thalamus or periventricular gray. But what I have found is that people with post-stroke pain, people with very widespread pain, like after cervical cord injury or something, I'm increasingly going for when I can get the funding in this troubled times, I go for the cingulate. And I still do bilateral cingulotomy for cancer pain.
And
but
if you do, for example,
pain is the problem is we're all surgeons, we try to make people better and we try for every patient. But what it does mean that if you try to publish a series to get an answer, as you are, as I am, none of the subgroups reach statistical numbers to get an idea. So I guess with many centers working across the world, people will get a better idea of which are the best indications. In support of that, I collaborate very closely with the university in Porto, at the Hospital São João, and they have looked very specifically at amputation and brachial plexus patients. And their results, by focusing on single or two indications, the results are very good. And it's sustained for years. So I think when we were starting, I started it 20 plus years ago, or nearly 30 years ago, if I was talking about lesioning for pain. But I think that our mistake was, or we didn't see it, was to try and treat everyone with pain, we didn't build enough evidence for individual indications.
Well, many questions, really many questions. It's very good.
Excuse me, please. Just one question to Professor Aziz. Comparing the results of stimulation and the lesion, anterior cingulotomy for pain and the stimulation for pain, what are the differences between the lesion and the stimulation?
Well, you see, I did lesions, thalamotomies, and cingulotomy for pain nearly 30 years ago. And if you do lesions for pain, after 9 to 12 months in benign pain syndromes, the pain comes back and you have to do more lesions. And then with time, you have to keep going back to do more lesions, and then you run out of target. So lesions are good, but better for people with limited life expectancy, like malignancy. Whereas stimulation, you can change the parameters. And so I get I'm not saying I will get success with everyone, but by implanting stimulators in the anterior cingulate, I can capture pain relief for a more sustained period in benign pain syndromes.
All right.
Thank you.
Thank you very much, Professor Manuel. Thank you very much, Professor Tipu. I would like, it's very it's very hard for me because there are many, many questions. I'm very happy. The persons, congratulations, Professor Tipu and the moderators. And I would like to begin. We have 10 minutes or a little more. I would like to begin with the questions. Let me read. Professor Tipu, do you think that the procedure would be better known as DBS of cingulate gyrus? It is about your cingulate gyrus DBS, of course. Do you think that the procedure would be better known as DBS of cingulate gyrus of anterior cingulate buttock, as it appears that the Tuckery dose activation produce a pain relief is the cingulate buttock and not the anterior cingulate cortex?
Well, as our technique describes, we always say that we try to put the electrodes within the white matter tracts. So, yeah, he has a point.
He has a point.
Hmm.
Do you blindly compare right versus left versus bilateral stimulation in your patients of cingulate gyrus DBS, of course?
Unilateral single stimulation doesn't work.
Thank you. And in contrast of the broader activation of this structure shown in PET studies, do you think is most posterior target in the anterior cingulate gyrus might provide greater pain relief than the target currently used?
It may well be different. If you look at lesion procedures, the target could be anywhere between 21 to 25 millimeters posterior to the frontal horn. But we have good success with the coordinates that were first derived by Ballantyne, and so we stick with it.
Paulo, do you mind if I interrupt and make a question just
Yeah,
to...
Of course.
Professor Aziz, when you stimulate the cingulate gyrus, how many contacts do you usually use? And do you tend to use the inferior ones or the upper ones? What do you think about it?
To the end, we usually ending up, I'm thinking of the last 4 that I've implanted in the last year. We stimulate across all 4.
Oh, 4.
So yeah, so it's quite a, we try to hit the whole bundle.
Yes. The next question, Alessandri, can I? Okay.
Sure.
The next question, what is the importance for you, Professor, of ventricular size in your trajectory calculation or target to ACC and thalamus?
In the thalamus, well, if the ventricle, as I said earlier, is very large, you cannot follow the somatotopy of the thalamus very well, because you're coming at an angle where the somatotopy is side to side. And also, if you were to apply the somatotopy and you transgress the ventricles, then you increase the risk of hemorrhage, which is why we always avoid that. And the same is true for the periventricular periaqueductal gray.
In the same line, do you have another question? Do you have did you have any of your patient having a stroke on the pericallous or callosal marginal arteries?
No, actually, well, that's an interesting question. In over 100 of our DBS patients that I've done in Oxford or my colleagues in Porto, we've not had a stroke. We've had infection in Oxford, but we've not had a stroke.
Thank you. Another question, can I?
Yeah.
Okay. Do you use stimulation of the motor cortex? Do you still using stimulation of the motor cortex to?
No, 20 years ago, we published our randomized controlled trial and showed that it was unpredictable and not as effective as some proponents would say. So we abandoned that.
Okay, next question. Is electrophysiological signature capable of predicting who responds and who not responds to treatment with DBS for pain?
We haven't been able to demonstrate that yet because, as I say, we do not have public funding anymore for DBS. So the research on that has become very limited in Oxford.
Okay, the next question, Professor, can I?
Mm.
Do you think that combining ACC DBS with PGV DBS could provide a relief for patients who have a subideal result with PVG DBS?
It's possible. It's possible, but we haven't been able to return to large numbers of DBS for pain unless there's been a change in government attitude to funding. But these are answers that could only come from trials, do you see? I believe there's a group in China that is looking at that, but not that I know otherwise.
This question came from Philadelphia, this last question. And then before this one came from Toronto, Canada. The next question, can I? 2 or 3 more? Professor, it is possible to safely conduct MRI studies in patients with fully implanted DBS system? For pain, of course.
That depends on what company you implant, because they have different safety guidelines. So the newer devices, you can, I believe, do MRI scans with a fully implanted device. But in the UK, on the whole, no one does it.
Keep going. Do you, Professor, what is missing to believe more in the use of preoperative DTI tractography in deep brain stimulation for chronic pain?
It may become more useful, you see. What I see with it is that it may make it possible to not have to depend on patients being awake for every procedure. Because one could conceive of having directional leads implanted in a best fit DTI target, and then you have the freedom to explore that area when the patient's awake after surgery with externalized electrodes.
Okay, the next one. Professor, do you know of any controlled study comparing thalamus and periaquedutal periventricular PAG, PVG in the treatment of neuropathic pain?
Not between the two targets. Our study, we very often implanted both targets because we couldn't, when we analyzed our results, find that one target was better than the other. But there's no trial. There's no trial. We have no trial of that particular. I don't know of any.
Thank you. In the same line, in DBS in PAG DBS, do you believe there is a specific position of the electrode to achieve better analgesia? The question is based on the selectivity for DA neurons, dopamine neurons, as is speculated. And he talking about a paper published by Norman.
I'm not familiar with that. And when we implant the PAG, PVG, we implant anatomically on the patient response, because if you look at our experience, the foot area lies at the level of the posterior commissure, and the face lies at the level of the inferior colliculus. And so we stimulate accordingly along those electrodes.
Thank you. Keep going. Professor, after your paper published in 2004, what is your impression today about the presence of somatosensory arrangement in the PVG, and how can it be useful for calculating the final position of the DBS electrode?
As I just mentioned, the final position depends on your on-table response. And you'll always find that the foot area is at the level of the posterior commissure and the face around the inferior colliculus. So as you approach the PVG area from the level of the posterior commissure, you advance the electrode, stimulating as you go along until you get this sensation of warmth in the right anatomical area.
Okay. One very friend from Portugal, from Porto, he would like to know your opinion about systematic immunological control in all cases, the importance of VAT and directional stimulation on pain treatment.
I didn't understand that.
I'm sorry, it's the importance of directional stimulation on the DBS pain treatment. The directional electrodes, I believe that.
I haven't used them so far. In pain, I haven't, because the directional leads came out after we lost public funding for directional. The person you could ask if you wanted to know is François Alèche in Vienna, because he is using directional in pain implants.
Now from Toronto. Thank you very much, Professor Tipu. I would like to know if you use the same frequency for PGV and sensory thalamus in DBS.
No, absolutely not. Periventricular gray, when we stimulate, it's very low. It's between 5 to 20 hertz. And it induces a sensation of warmth. And in the thalamus, it's usually 25 to 50 hertz. If we go above that in the thalamus, we can induce quite severe pain.
Next question is from Mexico. How do you select a contact to stimulation?
That's because if we stimulate the contacts, and the patient reports where the stimulation, and the contact that covers the area of pain is the one we activate.
Another question from Portugal. What your inclusion criteria for DBS in cancer pain?
Well, first of all, one of the main criteria is, it depends on your philosophy, you see. If most British palliative care physicians would rather a patient was run unconscious or semi-conscious on drugs rather than refer them to brain surgery. So in cancer pain, unless they have a coagulopathy, and if they can give informed consent, and if their life expectancy is less than a year, I would offer them a bilateral cingulotomy.
Okay, Professor, one question more is possible?
Yeah.
Is about insection effect. Is there any relationship between the insection reflex effect and the success of the stimulation test in patient with indication for pain?
I haven't formally looked at that, but I think there is. I think there is an association.
There is. Is useful to decide to implant or not? What's your opinion, Professor?
Well, if you're implanting the sensory pathway, like the thalamus of periventricular gray, it's always useful to trial the patient with externalized electrodes. So if you say there's a post-insertional effect, hopefully in the week after, you could confirm that with stimulation. The singulate's quite different. Stimulation there has, the patient doesn't report anything for the first. When we trial them, it takes days to show an effect. So nowadays for anterior cingulate stimulation, if we feel that the patient has a good chance of success, we just implant the whole procedure.
Right. There's too many questions, and many persons would say, thank you very much, Professor Tipu, from China, from South America, North America, Brazil, of course. Thank you very much, Professor. Everybody say, thank you very much.
Well, thank you for having me, Paulo.
I received a message from the organizer. We have 1 hour of meeting, and I would like to ask if Professor Antonio Almeida, Professor Antonio, could you finish our meeting today, please? I would like to say just every question will be answered. I will send for Professor Tipu, and I'm sure that they will answer all questions we don't have time today.
Yeah, I'm happy.
Thank you very much. But
Thank you.
Professor Manuel, Professor Alexandre, and Professor Tipu. Antonio, please.
No, let's just finish this first webinar of our society. It was great presentation. I think everybody who watched the lecture enjoyed it a lot. So it was really interesting. I thank you very much, Dr. Tipu, and all the panelists. I think let's make it again next week. Okay. Thank you very much.
Bye for now.
Saturday. See you again.
Bye.
Everybody, thank you very much.
Bye.
Bye. Thank you.
Health for everybody.
Bye-bye.
Bye.